Today's topic is a very important aspect of the clinical practice because we keep seeing conscious patient quite frequently in medical wards, and it being an emergency situation, one should be able to assess quickly and act quickly. So in that confusion of assessing and acting, one may go astray in the approach to the unconscious patient. So today's talk is to streamline your thinking of how to approach an unconscious patient. William James said that everyone knows what consciousness is until he attempts to define it. So it is so difficult, though it is so pervasive. What is important is to know that consciousness includes awareness of self and environment. That means we are fully conscious, we are aware of ourselves, how we are talking, how we are dressing, how we look. And we are also aware of the environment, people around us, the nature around us and all that. So that is consciousness. And please remember, there are two important aspects when you are looking into an unconscious patient. One is arousal is the ascending reticular activating system in the brainstem and thalamus. So this is the center for arousal. Awareness is the cerebral cortex. Now consciousness is a awareness. So that means we need a cerebral cortex to be aware of what we are and what the surroundings are. Whereas arousal is only when you pinch a patient, when you give a deep painful stimuli, the patient reflexly says, or moves his limb. Now that center is in the ascending reticular activating system. So you might be confused about brain death and brain stem death. Now the brain stem death is there is no arousal at all, but the brain death and brain stem death are one and the same, because it is the brain stem which relays further to the brain, and it is the brain stem which executes the brain function down. So if the brain stem is affected, then it is a brain stem or brain death. So they are synonymous, brain death and brain stem death. But remember, there are two important things. In brain stem, we always look for arousal, whether the patient is responding to pain and all that. In awareness, it is the cerebral cortex. Now, for example, when we sleep, we are not aware where we are sleeping, who is sleeping by your side and all. You are so deep asleep. But if somebody comes and pinches you, you immediately put your hand out and say, hey, don't disturb me. And you are not even aware that you have told them. So that is a brainstem which is acting. Because these two are important for future discussion. One of the clinical points we see is for example, a person who says, sir, he fell from scooter and is unconscious for 2 hours. Don't literally take it as unconscious. You ask him, was he lifted in an unconscious state, put in an ambulance and taken to the hospital? And you will be surprised to say how many of them say, no, sir, he was able to stand, walk, even he drove the scooter himself home, but he was unconscious. What the relatives mean is that he was not conscious enough to tell how he came home and what happened. So during that time, awareness was completely gone. So that's why it is called as a unaware. So whenever a person gives history that he was they will say he was unconscious in ICU for 2 days. Then I asked them a question. When you went to see the patient, was he turning his head to you? Was he mumbling something? Yes, doctor, he was doing, but he was not aware who we are. So there is a lot of difference between unaware and unconsciousness. Very important in the clinical picture. Now the brain is extremely demanding for their metabolic needs. On a continuous basis, it requires oxygen and glucose. Even though it has an excellent collateral blood supply, the circle of Willis, yet unless the blood supply carries the minimum of oxygen and glucose, the tissues will not survive. just because there is no storage capacity for the brain, unlike the liver which can store something. So that is why the brain is dependent upon a continuous blood supply of oxygen, glucose, and many other things. Very interestingly, brain just weighs 2% of the body weight, but it takes 20% of the circulation and oxygen, because it is the real machine which is very essential for the body to be aware and active. So it is a really generator, let us say. So what is the implication of this? Whenever the heart stops, like we see many of the hypoxic ischemic encephalopathy, heart stops for 2 minutes, 3 minutes. So those 2 to 3 minutes, there is no nutrients, no glucose, no oxygen going to the brain, and so the brain damage starts. So this is a very important point, why everything and anything can cause encephalopathy. Again, back to arousal and awareness. The level of consciousness refers to the degree of arousal. That means, is the patient fully awake? Does he require stimulation to awaken? The content of consciousness refers to the degree of awareness. So this is the degree of arousal. This is the degree of awareness. Content means patient is coherent or is he confused and inattentive. Both domains should be evaluated in a patient. Now, with that background of physiology, let us see the coma part. Coma is a symptom of underlying brain dysfunction. Like any part of the neurology, which I keep talking about, there is a stage of irritability and there is a stage of paralysis. Like a seizure is a irritability and postictal paralysis is a paralytic stage. So whenever there is a cerebral irritability, there is a confusion, disorientation, and delirium. When the brain gets further affected, then when there is a depression, patient may go into drowsiness, stupor, and coma. Coma is defined by Plum and Posner as a state of unresponsiveness in which the patient lies with eyes closed, cannot be aroused with appropriate stimuli or even with vigorous stimulation. Now, subsequently, coma has been defined objectively as a Glasgow coma scale, which many of you are well aware of. Now, as I said, the brain is dependent from not even minute to minute, second to second supply of blood supply, carrying oxygen, glucose, and so many other minerals and electrolytes. So with the result, anything and everything can disrupt the brain function. It can be oxygen, it can be increased carbon dioxide, it can be low glucose, high glucose, acidosis, alkalosis, low sodium, high sodium. So you can see that many of these can cause what we call as a metabolic electrolyte dysfunction causing encephalopathy. In fact, many cases of coma are non-neurological. Very few are due to primary neurological condition. Because of the situation, the brain is so highly dependent. Now, when a patient comes to unconscious state, please remember there are two anatomical localizations which can cause unconsciousness. One is a very focal lesion that is in the upper brainstem, that is the midbrain and the thalamus part. Upper brainstem is a midbrain and thalamus part, the lower diencephalon, which contains the reticular formation. So a patient who has got an infarct of vertebrobasilar insufficiency causing brainstem infarct involving the upper brainstem, the patient goes straight away into coma. Or there is a severe head injury, or there may be brainstem encephalitis. So there is a focal lesion with a devastating result. As against that, bilateral cerebral cortex can also give rise to unconsciousness. Now this is very important, bilateral cerebral cortex. Unilateral cerebral lesion does not cause unconsciousness. Please remember that. We have seen many patients with a dense hemiplegia fully conscious because only one hemisphere is affected. Second day, third day, you will find the same patient becomes unconscious because the cerebral edema in one hemisphere is carried through the corpus callosum to the other hemisphere, which becomes dysfunctional without any anatomical lesion. So that is a whenever a patient admitted in the hospital on day one, fully conscious with a dense hemiplegia, you should tell them that we'll have to wait for 48 to 72 hours. It is likely that he may become drowsy or unconscious, but we'll give all the medicines to prevent that. On the other hand, if a patient of stroke is admitted and he's fully conscious alert for 7 to 8 days, and he starts becoming unconscious on 9th or 10th day. See, as I told you, the unconsciousness comes on 2nd or 3rd day after a major stroke because the edema conveys the dysfunction through corpus callosum to the other hemisphere. So when does the edema occur? At 3rd or 4th day, and it lasts up to 7 or 8 days. After 8th or 10th day, if he is still unconscious, it is due to cerebral structural damage. But in a patient who was fully conscious for 8 to 10 days and then becomes unconscious, it is not due to stroke. It is not due to stroke. It is due to a general medical cause now getting into a picture. It may be pneumonia, it may be urinary tract infection, hyponatremia, hypoglycemia, a whole lot of works. So it's very important to say that the patient has another stroke. Unless you find another neurological deficit, patient who had a hemiparesis of 3/5 up to 7th day, on 8th day it becomes 0/5 and becomes unconscious, yes, that is a second stroke, which is quite rare as compared to general dysfunction, because already these people have hypertension, diabetes, CKD, this, that, and all that. So remember, after 8th day, if the patient becomes unconscious in a stroke, it is a systemic cause and not a neurological cause. So that is a time when there is a bilateral cerebral dysfunction is there. So remember these two, focal and generalized, and any unilateral lesion will not cause unconsciousness. You will see a large glioma, meningioma, and all sorts of things, but patient is fully conscious. Why this is important is sometimes we find a tumor of 4 centimeters sitting somewhere in the hyperparietal, and patient is admitted for unconsciousness. You should be thinking that how can this small tumor produce unconsciousness? Don't conclude, oh, MR scan shows tumor, and so this. MR scan, look at the size of the tumor. So the patient may be having hypoglycemia, hyponatremia, or any other problem, but not this responsible. So that is my main emphasis of today's talk, is to understand, to make you understand that unilateral cerebral lesion does not cause unconsciousness. Now we have different levels of sensorium. We say, I'll come back to the coma part of it, but there are other conditions where the patient may be so-called unconscious. So one of them is a persistent vegetative state, locked-in syndrome, akinetic mute, and the brain death. These are the 4 different items which you will have to understand. What is persistent vegetative state? There are no signs of awareness. That means what? Both the cerebral hemisphere is packed off. So he is neither aware of self nor aware of surroundings. That means the cerebral hemispheres are damaged. But he opens eyes, rolls the eyes, grunts and groans. That means brainstem is functioning. The cause is a diffused cerebral dysfunction. Location. Commonest cause in today's practice is a hypoxic ischemic encephalopathy. Head injury is other part, and then terminal stage of Alzheimer's disease. To give you a case example which we had, a hypertensive diabetic for 10 years complained of chest pain and sweating, was rushed to the casualty. By the time he came to casualty, he was already unconscious, no pulse, no BP. So the usual problem we see. He was resuscitated, no doubt, shifted to ICU on ionotropes and ventilator. Day 4 developed myoclonic jerks, which is a indicative of hypoxic ischemic encephalopathy. Day 8, he improved. Why? Because he's off inotropics, maintaining BP. Day 10, he further improved. Why? Because no ventilator required. But he remains to be unconscious, no response to deep painful stimuli, no further improvement. He was discharged at request in a condition of persistent vegetative state. That means it's something like a vegetable. It also has a life. The human being, this human being also has a life. But then the awareness has completely gone. Recently, the term unresponsive wakefulness syndrome has been proposed in place of vegetative state. Because vegetative state, you have to give an explanation what vegetative state means. But unresponsive wakefulness syndrome is self-explanatory. Patient is unresponsive, but he is awake because he looks around, eyes are open. So this unresponsive wakefulness syndrome is replacing the word vegetative state. It's characterized by spontaneous eye opening. Sleep-wake cycles are there. He sleeps for 6-8 hours, gets up, but he is not aware of self or environment. Now we move to the another case scenario. 35-year-old was admitted unconscious for 6 hours. Remember, whenever you take the history, the patient's relatives or patient himself will tell what is bothering that person at that point of time. But you have to extract the history, what was happening before that, before that, before that. So this patient was admitted in casualty saying that he is unconscious for the last 6 hours. When you started taking the history, patient had a progressive quadriparesis for previous 24 hours. So there is a quadriparesis and there is unconsciousness. So you think that it is a myeloencephalopathy, some virus disease causing a progressive myeloencephalopathy instead of encephalomyelopathy is going from down up. But on examination, yes, there is no response to deep painful stimuli. But when you started looking at the eyes, he had a normal eye movements and the pupils were normal. No, it is not a encephalopathy. You understand? So the brainstem is normal. How do you know the brain is normal? When you start asking him, now this is a case of what is called a locked-in syndrome. This is a case of GB syndrome, where he has lost the ability to move the limbs, he has lost the ability to talk, he has lost the ability to swallow, and his facial muscles are also paralyzed. Only the eye movements and eyelid movements are spared. That is called as a locked-in syndrome. Very neatly explained by the word, by the sentence, alert brain, locked in immobile body. That is a locked-in syndrome. You understand that? Alert brain, locked in immobile body. How do you say the brain is functioning? Cerebral hemisphere. We tell them, look here, if you are feeling pain in the stomach, blink twice. Then he will blink twice. If you are having hunger, blink once. So through this, you can make out that he is aware. He is aware, but he is not able to communicate because of the other factors. So this is called as a locked-in syndrome. Patient is fully conscious, aware of self and surroundings, but only communicates by eye blinking. And even in the eye, it is basically vertical movements as well as the eyelids. What is the cause? One of them is where the entire thing is paralyzed, like GB syndrome or periodic paralysis. And of course, the other one is a pontine infarction or myelinolysis, pontine myelinolysis. When you rapidly correct hyponatremia, they may go into this stage. So patient is brought saying he is unconscious, and you may also think, oh, he's unconscious, he's not moving a deep painful stimuli and all. When you go and look into the eyes and pupil, then you will suddenly realize this may be locked-in syndrome. Then we have other things like akinetic, mute, coma, vigil. They're all same as locked-in syndrome, but they also have bifrontal lesion. The final part of the, before we go to the coma, is the brain death. Brain death is absence of cerebral function as well as absence of brainstem function. Cerebral function, no response to deep painful stimuli. Absence of brainstem function, loss of eye movements, all sorts of reflexes are absent, cough reflex, dilated fixed. Most important is absence of respiratory movements. He is on ventilator, and you will see that the ICU doctor says that he has no spontaneous breathing at all. But The heart is working, the kidneys are working. So what is the importance of brain death? Say earlier we had only one death, either he is dead or not dead. Now we have two stages of death. First stage is brain death, second stage is the cardiac death. The previous one where we said persistent vegetative state is all because of our high technology of reviving a cardiac arrest patient. It's very good to revive a cardiac arrest patient and give him a life. If he's a youngster, 30, 35, he will come through. But a person with 70, 75, diabetes, hypertension, CKD, you revive him only to have a persistent vegetative state. Instead of coming to our hospital, if you had gone to a taluka or a district hospital where there is no ICU, where there is no ventilator, probably in another 2 minutes you would have been declared dead. Good for him and for his family. So the advantage is there with advanced technology. At the same time, we see the disadvantage of advanced technology of having revived a patient only to end up with persistent vegetative state. Now, why the term brain death has come? Because all other organs are functioning at that point of time except the brain, and it is extremely unlikely that the patient will survive. The whole thing is because of organ retrieval and organ donation. So that is the reason why the definition of brain death has come. And as far as I know, brain death is not legally certifiable as a death because the heart is still functioning. We are saying brain death only for organ donation. And there are, I think Tamil Nadu has got a government rule that anybody with a brain death must be informed to the government, that particular organization which retrieves the organs to the potential recipient. So that is the brain death. So when we see the no response to painful stimuli, no response to all sorts of reflexes, and most important is there's no breathing, zero breathing. And whenever you are talking of brain death, you must establish there is irreversibility of the state, which means that there are 2, 3 doctors who are involved, except besides the person who is treating, to give a certificate. Now we do clinically what is called an apnea test. Disconnect the ventilator, deliver 100% oxygen, placing the cannula into the trachea, observe the respiratory movements, check PO2, PCO2. If the PCO2 rises, then apnea test is positive. It supports the diagnosis of brain death. And we don't need this sort of a MR scan which shows there is a no more brain which is metabolically active. It is not that somebody has stolen the brain. The brain is not metabolically active, and so you find a total emptiness in a patient with brain death. But we don't need any investigations, neither EEG nor angiogram nor MR scan. Nothing is required. It is a clinical diagnosis signed by 3 different specialists. So now we come to the coma part. So how do we approach a patient with coma? There are 3 stages. 1, assess the level of unconsciousness. 2, why is he unconscious? Look for the cause by history, examination, and investigation. And lastly, management, symptomatic. If there is any specific cause, a specific treatment. Now let us see the level of unconsciousness. Now I see in my resident doctors and most of post-grad students, sir, patient is admitted, Glasgow coma scale of 5 or 15. I said, I don't know what is Glasgow coma 5 or 15. Please be descriptive. It is extremely important to be descriptive. As I keep telling, in practice, power 3 by 5 has no value. He is able to lift his hand for his food. He is able to get up from squatting. That is more important. Not power 3 by 5 is to pass the examination. But in practice, it doesn't work out. So don't describe imprecise terms, drowsy. The next fellow next resident doctor will say, sir, he is mildly unconscious. But he doesn't know what the previous doctor said as drowsy. So please avoid all these things. Go for a clear description of patient's actual condition and functional abilities. Because in ICU, I find people is, how is my patient? SSR, pulse, BP, oxygen, carbon dioxide, pH, this, that, everything they will tell. I said, please go to the bed, give a painful stimuli, and see whether he is responding or not. Look at the pupils and tell me whether it is reactive or not. This requires a human interaction, not sitting in one place and looking at the computer screens. You understand? As of now, fortunately, these things are not possible on computer screen. A human being has to go there. Coma scales are useful, but should not replace a complete neurological examination and descriptive terms. Now, what is the descriptive terms? You say that patient is spontaneously grunting and groaning and spontaneously moving right side of the body, not left side of the body. If he's not moving at all, give a painful stimuli and see what happens. Now let me go to the next. If he's spontaneously moving, please tell all these things. If he's not spontaneously moving, give an observation to deep painful stimuli in descriptive terms. Many times the physician refers the case as this patient is unconscious. When I go there and put a very deep painful stimuli, suddenly he lifts the hand and pushes my hand out. So you have to give a deep painful stimuli to assess the level of consciousness. If he doesn't respond to mild painful stimuli, give a deep painful stimuli. And very important, when you are giving a painful stimuli, please see that the relatives are kept out. Because when you are pinching so much here or over the sternum, they think already the patient is suffering and the doctor is coming and giving him more pain. They don't understand that we are doing it for the patient's benefit. So these are two important practical points: descriptive terms and keep the relatives away, and give a real deep painful stimuli when minimal painful stimuli doesn't have an effect. So you have to describe with minimal stimulus, head as well as forelimbs move vigorously, or the above movements occur by deep painful stimuli, or pain is, if he has response to the pain, if I am pinching the here, he takes his hand and puts somewhere here and there. So you say that there is no purposeful movement. That means what? It is a non-purposive movement, means he appreciates pain but he cannot localize the pain. Purposeful movement means he appreciates the pain and he tries to remove my hand. He localizes. See, each step is very important because yesterday the patient was responding but in a non-purposive way, and today the patient is responding in a purposeful movement. For a neurologist is an improvement. And I want to see whether he improves further. Because many times you'll say, sir, when is an unconscious patient becoming conscious? I said, there is no measurement, neither MR scan or blood report, nothing is going to tell you whether the patient is improving or not. These are the things which will tell. The patient who was not responding to pain, today is responding with non-purposive movement. After a week with purposive movement. After a week, he groans and vocalizes. So those are the steps of improvement. That's why today's class is very important for you to know how to examine a patient and how to proceed. So don't just use the word, sir, patient semi-coma or patient drowsy. It makes no impact at all. These are the small things which tells us, yes, the patient is improving. Even on ventilator, the least response to the pain. See, I tell the ICU doctor, you keep looking at the ventilator. She says there are 2 or 3 breaths per minute. And I give a deep painful stimuli and it goes up to 10 per minute. So that means there is a minimal response, not physically you are seeing, but the breath. That is the last thing to go in a patient who is deteriorating. The next thing we have to do after deep painful stimuli is the looking at the eyes and the brain. Now, many times I find the ICU is full of lights here and there. And then sister will bring a torch. You have to put another torch to see whether there is a light in this torch. And then you shine it like this and say, people not reactive. In a patient where he is unconscious, where we have to go into the level of unconsciousness, examination of pupil and eye movements are extremely important. So the room should be dark. I ask them to switch off all the lights around the patient. and the torchlight should be bright. That's very important. And then they examine the pupil. Examination of pupils gives us quite a bit of information. Small pupil, mid-sized pupil, dilated, unresponsive pupil. So it's very important that you look into the pupils and also you look into the fundus to see for any changes, for hypertensive hemorrhage, papilledema and all that. So please follow these things, very important. Eyes are windows into the brain. Even in your day-to-day practice, when a boy and a girl meet each other, the body language, and here it is the eye language, conveys much more than the writing a letter, aphasia. Similarly, the eyes are extremely important. They are windows into the brain functioning. Remember, out of the 12 cranial nerves, the 11 cranial nerves are peripheral nervous system. Only the optic nerve belongs to central nervous system because it is an outpouch of the brain itself. And so the eyes and the optic fundus are a window into the brain. The next thing is the breathing pattern. One of the important clinical point is we find patients are brought to casualty smelling of alcohol. Don't take it for granted that it is ethanol-induced unconsciousness. He might have fallen on the road and he has got a head injury, even though externally it may not be there, or he may be having hypoglycemia because he's a diabetic, he has not taken food. So it's a very, very important point. Even if you smell alcohol, don't conclude that it is alcohol-induced one. So there are different types of patterns of breathing which can give us some idea about the underlying part, like Kussmaul breathing, as you all know, metabolic acidosis. All physicians would have seen diabetic ketoacidosis. Very little exertion of the ventilation is sedatives, ataxic breathing, suggestive of lower pons, central neurogenic hyperventilation. Hyperventilation is there, but this hyperventilation is not peripheral. It is in the respiratory centers. So there is a deep and rapid breaths, 25 per minute. It suggests that there is a fontaine or big brain lesion. Chin-Stokes breathing occurs under several conditions. So level of consciousness, descriptive term, fundus and pupils, eye movements, and then breathing part. Then we come to the neurological signs. It's very important to know whether the unconsciousness is due to neurological problem or unconsciousness is due to systemic cause. The majority of patients are for systemic cause. So let us see how to clinically identify the patient as a neurological cause for which he has been brought for unconsciousness. In the examination, we already have seen ocular palsy, papilledema, conjugate eye movements, pupillary changes. That's why these are all very important to know whether the patient has got a neurological problem. And then if the patient has a lateralizing sign, lateralizing means we know that right-sided body is affected, hemiparesis, monoparesis, partial motor seizures. Localizing means cranial nerve dysfunction. The patient can have right sixth nerve palsy, not because there is a right sixth nerve structural damage, it may be due to raised intracranial pressure. So that they are called as localizing signs that he has got sixth nerve palsy, 10th nerve palsy. But hemiparesis, monoparesis is called as a lateralizing sign. So at the end of neurological examination, patient has a lateralizing or localizing signs means it is a neurological cause. Patient has no lateralizing signs, no localizing signs, but only signs of coma, like pupil, patient has got a vestibular reflex absent. Those do not give rise to the neurological cause. You can diagnose hemiplegia in an unconscious patient. Of course, you give a deep painful stimuli. If he moves the left upper limb, he is not moving right upper limb. Even when you pinch right upper limb, he moves the left upper limb. We know that the patient has a right hemiplegia. But in a patient who cannot respond to the painful stimuli, lift both the hands like this off the bed and you yourself wave both the hands. With your hand, hold the patient's hand and lift like this. You can feel a weighty hand, the paralyzed hand. Paralyzed hand looks heavier. Remember, a dead body is much heavier than when a patient is alive. Similarly, a dead limb is much heavier. So when you weigh like this, you can make out. And the next thing you do is suddenly you leave both the limbs. The paralyzed limb falls with a thud. The unparalyzed limb falls a little slowly. So you can make out patient has a hemiplegia even in a patient who is not responding to pain. If he responds to pain, there is no problem. So weighing the limb is very important clinical pointer. Then we look for the brainstem functions, which we have already told you in the examination. It is pupils, Dolce maneuver, cold water caloric test. Dolce maneuver is very important, where you find the turn the head suddenly and see whether the movement of the eyes are in the opposite direction. You turn the head suddenly, you stand at the head end of the patient. Don't turn like this. You stand at the head end of the patient, hold the head, and then quickly turn to the right of yours. You will see the eyes are moving to the left. And then quickly turn to the left of yours, the eyes are moving to the opposite direction. So that means the brainstem is intact. Pupils are reactive, brainstem is intact. Patient has got asymmetric pupil, that means there may be an intracranial lesion. So this is the level of assessment to see whether the brainstem is functioning or not. When do you look for brainstem functions? When the brain function is gone. What is the brain function? No response to deep painful stimuli. There is no response to deep painful stimuli. You want to know whether there is a brainstem dysfunction, which is a step towards the brain death. In brainstem dysfunction, there is a dysfunction. There is no absence of function. Absence of function is a brain death. Many times in our ICUs, when we go there, we look at this and say, patient has 10 per minute breathing is there. Pupils are mild. So let us resume this. I think the first half is a very important fundamentals which I have said. So the second half, I can speed up a little more. So the idea of brainstem dysfunction is different, brainstem death is different. So as long as there is a function, some breathing is there, some people is reacting, then we say there is a brainstem dysfunction. When nothing is there, including apnea test, we call it as a brain death. So you know about Glasgow coma scale, which I personally do not practice Glasgow coma scale because I believe in a descriptive terminology than Glasgow coma scale. So you may, for your examination, do that. I have no problem. But remember that it has got less important than a descriptive terminology. Now, one more thing you see in an unconscious patient, if you find there is a flapping tremor, it gives you a clue that the cause of this unconsciousness is metabolic or drug-induced encephalopathy. So you should lift the hand and then you see the patient has, so this like a flap. So flapping tremor is very characteristic, what is called as asterixis of a metabolic cause. It won't happen in neurological. If you see multifocal myoclonic, very common in hypoxic ischemic encephalopathy, day 3, the myoclonic, first the muscle will start twitching, and then there is a myoclonic jerk, and then there may be a complete generalized tonic-clonic seizure. So these are all the assessment of level of unconsciousness, which I have told you so far. Then once you have assessed and said, okay, this patient has this problem, then we are interested to know the cause of unconsciousness, which comes from history, examination, and investigations. History and examination should guide us what further testing we should do. Should we do a toxicology screening? Should we do electrolyte screening? Should we do an MR? Should we do an EEG? It depends on what you have come to a conclusion. Step 1 and step 2, what is the neurological deficit and what is the anatomical localization. If you think it is structural anatomical localization, obviously neurological testing will be there. So history and examination is very important. Often several tests are ordered at random. Get an MR done, get a Doppler done, get a CSF done, get this done, get this done. What happens is not the cost only, but there is an unclear relevance of so many things. Somebody has got vitamin B12 low, sodium is 128. Now, whether that is responsible or patient has taken anti-epileptic drug intoxication. Back to clinical neurology. Back to clinical neurology. So, random testing everything to be done at one go is not right. Step one investigation, step two investigation. Now, how do we approach unconsciousness without localizing? That means no third nerve, sixth nerve, seventh nerve, no cranial nerve dysfunction, and without lateralizing, no hemiparesis, no monoparesis, no paraparesis like that, is one group. Second group is unconscious with lateralizing. Somebody has a commonest is unconscious with hemiparesis, or unconscious with sixth nerve palsy, third nerve palsy. The third group is unconsciousness with signs of meningeal irritation. That means we know that we are dealing with that. So what is lateralizing, what is localizing, I explain. If you find a patient is unconscious, there is no lateralizing signs, there is no localizing signs. Commonest cause is all systemic causes which you as general physicians are well versed with. It can be systemic infections, systemic infection without meningitis. This is very important. Patient has a urinary tract infection, 78-year-old, hypertensive, diabetic, he comes with unconscious state. You just treat urinary tract infection, he becomes conscious. That is called a septic encephalopathy. And whole lot of metabolic disorders, electrolyte disturbance, acidosis, drug-induced hypertensive. And so all these are, you have gone to step one saying that this is unconsciousness without lateralizing, localizing. First is a systemic. When do you suspect neurological? Unconscious without localizing, lateralizing. Patient who has got a head injury, encephalitis, where the patient is unconscious because the entire cerebral hemisphere on either side is affected, or post-seizure state, again post-ictal coma, or very rarely electrical status epilepticus. These are the causes of unconsciousness without lateralizing. So the bottom line is, when you find unconsciousness without localizing, lateralizing, diligently look for the entire list of causes. And most of them are eminently treatable causes. If you don't find any of these, then you may have to look for neurological causes. Now, give you a couple of examples. A diabetic, one of my relative patients, diabetic dementia on glycomate donepezil, hallucinations, prescribed quetiapine. A month later became drowsy. I said, okay, stop quetiapine. Checklist, see what are all the sedatives. Protein tests and MR brain also, they got it done normal. No history of fever, no lateralizing, localizing. Just give broad spectrum antibiotic. Patient became alert next day, fully conscious. To an extent, she started again hallucinating. This is a septic encephalopathy. Without affecting the brain or meninges, brain directly, infection somewhere increases metabolism. Already the patient is at a low level of cerebral activity, and that increases cerebral metabolism, and so the patient goes into unconsciousness. This is one of the common causes of unconsciousness in general medical wards. Brought to casualty in unconscious state 6 hours, no comorbidity, no history of fall and all that. CT head scan, because there was all preliminary investigations were normal, so we go to the second level of neurological investigation. There is an acute hemorrhage or the chronic hemorrhage, subdural hematoma. In the elderly, even in the absence of head trauma, consider subdural hematoma. Why? Eminently treatable condition. Patient himself might have fallen in the bathroom. He has not told anybody, and he is now unconscious. He can't tell you the story. So don't say there is no history of head injury. You have to get a CT scan done. Now look at this. We come across these cases fairly frequently, I must say. 26-year-old casualty, unconscious state, 4 hours duration. no comorbidities, no fever, no step drug intake and all. People's normal reactive, no response to deep painful stimuli. So you will naturally feel this is a organic. Patient is not responding to deep painful stimuli. But with the history, you will find the patient had a fight with her husband, and then after some time, she suddenly became unconscious and she is not responding, even after sprinkling water, deep painful stimuli. So you suspect that this could be functional or psychogenic. Now, how do you make a diagnosis? Lift the limb off the bed, like I said, weigh the bed, weigh the limb, and then wait for some time, and then suddenly leave it. It takes a few seconds to come down, and then it comes down tuck like that. So that means the patient is conscious. In a hemiplegic, it immediately falls down. Here, if you lift it and leave it, it falls down. Lift it and keep for a few seconds or a minute. So the patient is not aware when you are going to drop. So when you leave it and drop, it comes a little slow and then comes down. That is one clinical point. The second point is eyelashes. So touch the eyelashes. Then you'll find the eyelids start blinking. That means the patient is fully conscious and alert. So that is a psychogenic unresponsiveness. Don't order a list of investigations, MR brain, LP, EEG and all that. Clinical diagnosis. This was another patient of mine, a priest by occupation. He was found unconscious in the morning. No comorbidities, no lateralizing, localizing, no neck stiffness. So that means look for a systemic cause. But all primary investigations are completely normal. This is a very important point. Pupils are normal reactive, but doll's eye movement is absent. This combination, doll's eye movement absent with a briskly reactive pupil, is a diagnostic of phenobarbital poisoning, which we used to see quite often earlier when the anti-epileptic drugs were phenobar, phenytoin, sodium valproate, carbamazepine. Now all of you, at the drop of a coin, you say levetiracetam, levetiracetam. So we will not see this. Now, another example where the patient has no lateralizing localizing feature, but yet it is neurological. It is a viral encephalitis. So you find a patient has headache, fever, seizure. Because it is a seizure, you know it is a neurological, but seizure can occur in hyperosmolar state, hyponatremic state. Seizure does not mean patient has a structural lesion. So again, all the routine first line investigations, sodium, potassium, this, that, etc. are normal. MR scan shows it classical evidence of basal ganglia hyperintensity suggestive of Japanese encephalitis. This is again a message unconscious without neurological deficit. This was a last week a patient, diabetic, admitted in unconscious state. Diagnosis was non-ketotic hyperosmolar. The physician was treating this. Second day he developed a right hemiparesis, which is a complication of non-ketotic. Third day he developed focal seizures, again a complication of non-ketotic. Then fifth day he became unconscious and febrile. So the physician wanted me to tell whether he should go ahead with a lumbar puncture. I said there is no need. This is a septic encephalopathy. There is no neck stiffness, and this septic encephalopathy is much more common than the pyogenic meningitis. So I said this is not required. You just change the antibiotics, and within 36 hours he recovered with change in antibiotic. Again, septic encephalopathy. Now we go to the second group, unconscious with lateralizing. This is a common one which you see in a day-to-day practice. A patient has a dense hemiplegia and then he becomes unconscious. So this is very commonly seen. So with lateralizing or localizing, like a brain tumor with a sixth nerve palsy. So either it is a space occupying lesion or a infarction or a demyelinating lesion, which is very easy. Once you find lateralizing, localizing, the primary investigation includes MR scan. When you don't find lateralizing, localizing, the primary investigations are the whole lot of electrolyte, PA2, PCO2, sodium, all those things, and then nothing is coming through there, then you go for neurological. So these are the one where the patient has an infarct in the cerebellum, a large infarct in the cerebrum, a huge tumor. So these are the one which has got lateralizing, localizing. So it's very easy to make a diagnosis. The third group is where the patient has signs of meningeal irritation. Remember one thing, when a patient is comatose, the neck stiffness will not be there. And it is important to realize the neck stiffness is to prevent the pain. It is a reflex action of the patient to prevent the pain. Because when you bend the head, the meninges are stretched like this. An inflamed meninges is more painful. When you keep like this, the meninges are not stretched. So the patient has neck stiffness only when a patient is conscious enough to appreciate the pain. If he is in a coma due to meningitis, there won't be any neck stiffness. Still, you have to make a diagnosis. So patients unconscious with signs of meningeal irritation or without meningitis, subarachnoid hemorrhage. 43-year-old lady, sudden severe headache, brought to casualty, unconscious, no neurodeficit because the patient was deeply unconscious. Because of the history of sudden severe headache, primary investigations quickly done and also a CT done. You can see the subarachnoid bleed here, primary subarachnoid hemorrhage. There's another interesting case here where the patient has, he came from the office by 4 p.m. By 9 p.m. he became unconscious. So naturally the relatives thought he must have taken some drugs and he's unconscious. Remember, no fever. Patient has mild neck stiffness. Yes, no. The way I express is mild but definite. If you are not sure, you say that probable neck stiffness, yes or no. But if you are sure there is a neck stiffness but mild, please say definite mild stiffness. And then a CSF shows a pyogenic meningitis, such a rapidly progressive unconsciousness with no fever. But here the CSF showed meningitis. Now that is a clinical examination, specific investigations. The general investigations, I don't have to elaborate on this: urinalysis, hemogram, blood chemistry, electrolytes, ABG and all that. And whenever these are normal, you do an MR scan. When that is also normal, or even simultaneously, you can send for toxicology screening for various drugs, especially if the patient is on anti-epileptic drugs. When should you do neurological investigation? That is MR, EEG and LP. In presence of a neurodeficit or meningeal signs, of course, definitely. You do an MR scan, meningeal signs, you do a CSF after an MR scan. And when systemic causes are not detected, that means the preliminary round of all these investigations are normal, and yet the patient is unconscious, you have of course sent for toxicology screening. Then definitely you do a neurological investigation. The first one you do is always an MR scan. EEG is only helpful when you suspect electrical status. Otherwise, routinely we don't do EEG in an unconscious patient. When should we do an LP? Or can we do an LP in an unconscious patient? Yes, if you do an MR scan, if it doesn't show any space occupying lesion, then there is no problem. You can do an lumbar puncture. But suppose there is no space occupying lesion and still patient is unconscious, is there a possibility that there is a cerebral edema, and if you put a needle, the patient may cone and die? So what we do is, if the patient doesn't have cerebral edema obviously, or if you are worried about possibility of cerebral edema, we give the patient mannitol 20% 100 ml over a period of 30 to 45 minutes, and an hour later you can do a lumbar puncture, provided not a routine, no, do LP also, provided you suspect, you will get a diagnosis. I always maintain, whenever you order for investigation, ask yourself whether it will give you a change your diagnosis or whether it will change your management. So if you think LP is mandatory in this patient, if MR scan shows or doesn't show edema also, give mannitol and do a lumbar puncture. Now just a couple of cases. A patient of 46 who came with a slow progressive drowsiness and unconscious in 10 days no fever, no headache, no vomiting, no lateralizing, localizing, no neck stiffness. So you do an MR routine test, normal, MR brain normal. So what are you left with? Lumbar puncture. Don't forget, lumbar puncture is a very important investigation. After the first round of general investigation, then an MR scan, both have not given you answer. You must do a lumbar puncture. So a lumbar puncture showed a TB meningitis. Don't forget to do LPCSF when first line investigations are normal. Another important clinical point, rapidly regaining consciousness. Somebody who was unconscious, deeply unconscious, they lifted him and put him in the bed on the car. They brought him to casualty after half an hour. He has regained consciousness. Commonest cause is a seizure. They might not have seen the seizure. They went to the bed to wake him up. They found he's unconscious. They bring him to the casualty. After half an hour, he becomes conscious. Probably he had a seizure and he was in a post-ictal coma. What are the other possibilities? Spontaneous and rapid resolution, hypoglycemia. The body corrects itself, the hypoglycemia, and so the patient becomes conscious. Or it may be a head injury with a concussion. He was unconscious for an hour or two and then becomes conscious. Or a stroke, TIA. Patient had a vertebrobasilar stroke, unconscious, he recovered, he had a dysarthria to say that it is a VBI, but by the time the relatives came to him, he became conscious. Or he had dysarthria on the way which they have not noticed, but when they come to casualty, they are normal. So remember, spontaneous and rapid resolution of symptoms, these are possibilities. The second group, very important, is a fluctuating level of consciousness. Fluctuating level of consciousness. That means today is drowsy and by evening he becomes conscious and next day he becomes drowsy. Always systemic causes. Always systemic causes. Metabolic, electrolyte, toxic, endocrine. The only neurological conditions with fluctuating consciousness is subdural hematoma, which you would have by now excluded with a CT scan. Therefore, in practice, with fluctuating level of consciousness, if CT and MR is normal, one should diligently look for general medical causes. It may be marginally low sodium, marginally low glucose, marginally low POO2, marginally high PCO2. Each by itself is not responsible, but all of them put together has caused this fluctuation. So these two, I think, is a very important clinical point for you. This was a very interesting case of mine. This was before the sodium, potassium was available for us. We didn't have all those. We didn't have CT, MRI, serum sodium. You may be surprised. We practiced at a time when a patient had a chest pain. We asked for an ECG, and the next morning the technician comes and takes ECG because there is no such thing as emergency ECG. Simply because even if you diagnose, we didn't have coronary angioplasty, this, that, and all. Okay, so that time, patient was admitted to right hemiparesis, left cerebral infarction, recovered, and readmitted with altered sensorium, diagnosed as recurrent stroke, recovered again, but episodic unconsciousness. As I told you, episodic unconsciousness, systemic cause. We investigated him. We found that he had a Sheehan syndrome, postpartum necrosis. Anyway, the final diagnosis was Addison's disease. How was she improving? Because every time IV saline was given. See, those days the practice is the moment a patient is admitted in unconscious, even today, first you connect the drip so that the relatives think that you are doing something. So if the drip contains saline, the patient became conscious. So recurrent altered sensorium is always due to systemic cause. The final one, management, of course, it depends on what is the cause. Symptomatic management, maintain the respiration, maintain the blood pressure, maintain the nutrition and all those things. Specific, if you have made a diagnosis. Unconsciousness is a time-sensitive medical emergency where you have to stabilize the patient, airway, circulation, breathing. So all those things have to be stabilized. And even in the absence of trauma, in older patients, ask for anticoagulants, brain injury and all that, you will of course do a imaging after the preliminary investigations. But you all have been fairly well impressed that the first and foremost advice in the management of comatose patient, somebody is taking the interest history, tell the sister to give 50% 50 cc glucose immediately, because hypoglycemia, whether patient is diabetic or not diabetic, whatever it is, you must give, because that is one which is dramatically the patient improves. So immediate management, you know all these things. Specific treatment depends on the underlying etiology. Reversible causes of coma are more likely, this is a very important point. Reversible causes are very likely when imaging of the brain is unremarkable. First line of investigations, characterize this, that, and all that normal. Second line, you do an MR scan. We don't do EEG and LP only when it is necessary. So you find that MR scan is normal, preliminary investigations are normal. Then what are we going to do? Look for all other causes which are reversible. Endocrine dysfunction. I have had patients who had a hypoadrenalism detected at that time. So by giving steroids, they became conscious. So you have to do cortisol level in the morning, fasting state and all. So you have to go into the deeper and deeper general systemic cause. So please remember, reversible causes of coma, they are all eminently treatable. Imaging of the brain and first round is normal. Look for toxicology screening. Of course, you may do a lumbar puncture if you are not sure, and then look more and more you dig into the systemic causes. Remember, in neurology, step 1 and step 2 are very, very necessary. Step 1, the patient has coma with no lateralizing localizing deficit. What is the anatomical localization? Cerebral hemisphere. That is step 2. So step 3 is pathological diagnosis. So confirm anatomical localization by doing an MR brain. Pathological diagnosis is easy because it depends on history. Sudden onset of loss of consciousness, maybe subarachnoid hemorrhage or head injury. The fourth step is the etiological diagnosis, provided you have followed this 1, 2, and 3. If you just blindly put all sorts of investigations, you will never be able to achieve the goal. So please go up step 1, step 2, 3 and 4 is easy. 1 and 2, you'll have to really go into the depth and write down 1 and 2. 3 is very easy, acute, subacute. 4, you can go and refer the books, acute onset of unconsciousness with no lateralizing deficit. So there will be a long list. Come back and ask for more investigations. Very simple. So summary, clinical approach to an unconscious patient is no doubt to be done speedily. However, it should be in a proper stepwise approach, depends upon eliciting good history and a quick physical examination. Simultaneously, emergency measures have to be done. So those of you who have not taken my book, for your practice and for your, see, I am a grassroots neurologist. I am also called, I call as a non-invasive neurologist. So I don't invade either stroke or movement disorder and all. So basic clinical neurology made easy, available Amazon as well as in my neurology clinic, neurology OPD.